My name is Chris Paxson, and I'm Dean of the Woodrow Wilson School, and I'm delighted to welcome all of you here today. This is kind of a special lecture. We have lectures every day, or almost every day, and this is an inaugural lecture. It's the inaugural Gilbert S. Omen Class of '61 Lecture in Science Policy, and something that I'm very excited about having here at the Woodrow Wilson School. Unfortunately, Gilbert Omen, whose wife Martha Darling is here, is about 10 minutes away. He's coming in from Newark, so he's not going to hear what I have to say about him. But I will still be very flattering. So Dr. Omen is a really interesting man. He is a professor of internal medicine, human genetics, and public health at the Center for Computational Medicine and Biology at the University of Michigan. And he's somebody who has had a career that has really spanned policy and science. Early in his career, he was Associate Director of the Office of Science and Technology Policy and Associate Director of the OMB under the Carter administration. And then he went on from there to a very distinguished career in academic medicine, working on things like chemoprevention of cancer, public health genetics, science-based risk analysis, and public policy. His MD is from Harvard, his PhD in genetics from the University of Washington, but his BA is from Princeton. And he and his wife, Martha Darling, have been very strong supporters of the university. Martha is a graduate of the graduate program in the Woodrow Wilson School. So Dr. Omen served for a while as president of the American Association for the Advancement of Sciences, actually in 2005. And his presidential address was titled Grand Challenges and Great Opportunities in Science, Technology, and Public Policy. And it's published in Science, it's a great article, and it really urges scientists and students to tackle some of the world's most pressing problems in mathematics, genetics, environmental sustainability, and global health. And this lecture in science policy that we will have every year will really take a broad look at really important issues in science policy. So we're taking this lecture to be very much in the spirit of what Gil has done over the course of his career. So with that, I'd like to introduce our first speaker in this series, and that is Dr. Christopher Dye. He is Director of Health Information in the Office of HIV/AIDS, Tuberculosis, Malaria, and Neglected Tropical Diseases at the World Health Organization. He started his career as an ecologist in the UK. For a long time was based at the London School of Hygiene and Tropical Medicine, where he headed the school's vector biology and epidemiology unit. He joined the WHO in 1996, where he's really had the opportunity to bring his scientific knowledge to bear on policy issues. Under his guidance, WHO has moved forward to develop methods for national surveillance and survey data to study the dynamics of diseases, TB, other communicable diseases. Dr. Dye is also a visiting professor of zoology at the University of Oxford, a member of the Board of Editors of Science, and a fellow of the UK Academy of Medical Sciences. And his talk plagues pandemics and policies for health, a great example of alliteration, but also something very interesting. So I'm looking forward to it. Please welcome.
Thank you very much for that introduction. It's a great honour to be invited to give the first lecture in this series. So Dean Paxson, Dr. Omen, when he arrives. Ladies and gentlemen, my interest is in how we get from science to policy and then from policy to action. And that's what I'm going to talk about today. I'm going to introduce my lecture with 3 remarks, and then I'm going to address 4 questions that I think are important to global public health today. So the first of my remarks is that I work for the World Health Organization, as you can see up on the screen. But what I'm going to give you today is very much a personal view. It's not the official view of the World Health Organization, and I think that will become clear as I speak. The second is that Chris Paxson already referred to the alliteration. Now, if I could have got a 4th P into the title, which would have been very bad alliteration, you can only have 3, you can't have 4. If I would have had 4, it would have been people. And as I thought about what I was going to say to you today, the images of a number of key people came into view. And I just want to show you some of the pictures of those individuals. And as I thought about who they are in the scheme of science, policy, and action, these are people who align themselves on a spectrum at the top from heroes on the left to villains on the right, and at the bottom, scientists and public health workers up to policymakers going up towards the top. I'll just give you a tour of the table here, starting at the bottom left. Right in the bottom left-hand corner, the man in the middle here, who it's very difficult to find a good picture of, is Karol Stiblow, a modest man who was essentially the architect of the policy that we use now in tuberculosis for global tuberculosis control. He devised what we now call the DOT strategy. To his right is a man called Arata Kochi, who was my first boss in WHO. And I've put him to the right, not because he's really a villain. He doesn't quite fall into that category. He was a brilliant public health strategist with an edge. And whilst he wasn't villainous, he certainly was mischievous at certain times. And he was one of the reasons that I continued to work for WHO. In the middle level, on the left here, you see Sir John Crofton, and next to him a man called Fengzheng Zhao. And both of these are essentially saints of international public health. John Crofton was the man who devised the approach to tuberculosis control combination drug therapy and began to use that in the United Kingdom. Dr. Zhao, in the middle there, is somebody I've had the privilege to work with, whose sole purpose in life has been the care of tuberculosis patients across China, and he's done a magnificent job. To the right of him, in black and white, is a man called Mark Harrington, who works for the Treatment Action Group in New York, HIV positive, an HIV activist from an early age. He's been a thorn in the side of the World Health Organization, I think, in a very productive way, and he's one of the people I admire in this field. Top left, you see Archbishop Desmond Tutu, a familiar face. He is an erstwhile tuberculosis sufferer, a long-standing supporter of public health in South Africa, tuberculosis and AIDS control. And just to his right, you might be surprised to see George Bush Jr. Well, you'll know about the President's emergency plan for AIDS relief, and he was the President in question, and he was the President that made sure that it was stocked with a large amount of money. To his right, President Museveni of Uganda was one of the people that took early control of the AIDS epidemic in Uganda by implementing the so-called ABC strategy, abstain, be faithful, and use a condom. And that had a big effect in Uganda. Unfortunately, more recently, it's become a little bit less C and a lot more A, I think to the detriment of AIDS control. And on the right-hand side, I've left clear daylight with the three on the right-hand side there, because these are true villains. At the top, you see President Mbeki, who was an AIDS denialist and responsible for the refusal to treat HIV/AIDS seriously, take it seriously in South Africa. His health minister just below him, who advocated the use of lemon juice and beetroot for the treatment of HIV-positive people. And just below him, in the bottom right-hand corner, Peter Duesberg, the pseudoscientist, whose views that they relied upon to support their case. So we're dealing with a patchwork of heroes and villains, true scientists and public health workers. And we can talk about the science, and I'm going to talk about the science, but I think we have to keep in mind the important fact that what gets done in public health is down to the people who are doing it. And this is an illustration of the diversity of people we're working with. My third introductory remark with respect to the title on plagues and pandemics is this. When people talk about plagues and pandemics, they expect diseases like the ones you see on the left. Top left, cholera; top right, plague itself; then SARS, severe acute respiratory syndrome; outbreaks of influenza; perhaps novel vector-borne diseases, and so on. This is what we commonly think of plagues and pandemics. But I want to focus on two other plagues and pandemics in this talk: AIDS and tuberculosis. AIDS because it is the pandemic of our times, and tuberculosis because, well, when the Director General of WHO declared the recent swine flu outbreak as having reached pandemic level 6, Our reaction in the tuberculosis section was, well, if that's the definition, tuberculosis has been at pandemic level 6 for at least 100 years and possibly thousands of years. And therein lies one of the problems with maintaining interest in tuberculosis control. It remains a pandemic and it's not yet under control. And that's what I want to talk about. Specifically with respect to AIDS and tuberculosis, I want to address these 4 questions. The first 2 are a bit longer and 3 and 4 are a little bit shorter. First of all, with respect to tuberculosis, we commonly hear these days about the end of the antibiotic era. I want to examine what that concept might mean for tuberculosis, an important bacterial infection treated with antibiotics. Secondly, with respect to HIV, the development of antiretroviral drugs to treat HIV/AIDS has been one of the spectacular developments in medicine in the last 25 years, I'd argue. But the emphasis, up until very recently, in using antiretroviral drugs has been on maintaining the health of individual patients and extending their longevity. But we know that these drugs are very good at killing virus, and that should have implications for transmission. And one of the questions we've explored is how good are antiretroviral drugs at reducing the transmission of HIV and hence the incidence of AIDS. The third question alludes to the problem of keeping tuberculosis in the news. I'm going to talk about a recent campaign I've been involved in, which addresses the issue of how many lives we can save from tuberculosis among people who are HIV positive. And the last question that I'll deal with very, very briefly, looking forward into the future, because it's a different relationship about science and policy. It's really about science influencing research policy rather than public health policy itself at the moment, is the question of whether we can come up with a better vaccine. So the first question, are we coming to the end of the antibiotic era so far as tuberculosis is concerned? And as you see in red at the bottom of the slide here, this is really a question about managing, in the science policy domain, it's a question about managing the balance between threat on the one hand and opportunity on the other. And I'll explain to you what that means. First of all, a little bit of background. Antibiotic resistance is talked about all of the time, and the World Health Organization talked about it this year on World Health Day, which takes place in April every year, under the slogan, "No action today, no cure tomorrow." Now, WHO, in this context, we're not talking just about tuberculosis, of course, but all bacterial infections that are treated with antibiotics. But tuberculosis is an important example, and this is part of the backdrop. And that slogan is an interesting one-liner, and I think a useful one, but the truth behind it is a lot more subtle than illustrated by this slogan. Here's what happens for tuberculosis. The problem with TB with respect to antibiotic treatment is that the course we have at the moment is a long course of treatment which involves combinations of drugs taken for at least 6 months, like this young boy in Ghana is doing under supervision. You can see in his right hand he has a collection of tablets. He's got to take those on a daily basis or 3 times a week for a period of at least 6 months. Ideally, he would have a fixed dose combination, just 1 pill instead of 3. But he needs to get to the end of that course of treatment, or he's very likely to fail. And if he fails, he is likely to become drug resistant, because tuberculosis among bacteria very easily develops resistance to drugs. Now, the problem of resistance we have known about for a long time, and we've mapped it in WHO for a long time. And this is the latest of our maps of the distribution of so-called multidrug-resistant TB, which is tuberculosis resistant to at least the 2 main drugs that we use to treat infection. That's isoniazid and rifampicin. And as you will deduce without bothering to read the legend, green is good, yellow's not bad, and red is very bad. And these are the rates of resistance in different countries around the world. And you can see that in terms of rates per capita, it's the former Soviet countries that are worst affected. But you'll see that large countries, particularly China, are also orange. And when you multiply moderate rates by very large populations, you get a large resistance problem in total. So those are the countries that we're concerned about. We've been concerned about them for some time. But The game has been upped recently by a body of new information that's come available to us. On one level, it's information about the details of drug resistance in different countries, like these data from the former Soviet Union. The graph on the left is the cold reality of the statistics. That is, resistance rates among patients in blue who have developed tuberculosis for the first time, and patients in orange who are coming back with repeat bouts of tuberculosis. And you can see very clearly that the rates of multi-drug resistance are very high in patients who have relapses, of the order of 50 to 60%. And that's an enormously high rate of resistance. Now, the statistics reflect what you see on the right-hand side, which is the clinical reality of tuberculosis treatment in some of these settings. This is a patient who has been detained in prison, who has had a surgical intervention to deal with untreatable drug-resistant tuberculosis, lung section, because treatment was failing and there were few other courses of action available. And this additional data at the country level underlines the problem that we're dealing with. But there have been other events more recently that have highlighted the problem of emerging resistance. And one of those is the outbreaks of so-called extensively drug-resistant TB, or XDR TB. Now, whereas multi-drug-resistant TB disease is resistance to 2 drugs, extensively drug-resistant TB is resistant not only to first-line drugs, but also to 2 classes of second-line drugs as well. It's extremely difficult, in other words, to treat. It was labelled XDR by the Centers for Disease Control here in the United States in a stroke of policy-making genius, in my view, because X is easily the most intimidating letter of the alphabet. What happened, and what drew an enormous amount of attention, happened at a place called Tugela Ferry in KwaZulu-Natal in South Africa, and the pictures illustrate that setting. And this was the clinical reality in this hospital ward. 53 patients were admitted to this ward. They were found to have tuberculosis. Half of them died within 16 days. Now, the initial reaction to that stark fact was that we were dealing here with a new and particularly virulent form of tuberculosis that was going to spread very quickly across South Africa and possibly the rest of the world. The reality, in fact, was that these patients were all late-stage HIV-positive individuals, most of whom had acquired infection on the ward itself through a failure of infection control. So it shouldn't really have happened. Nonetheless, it is extensively drug-resistant tuberculosis, and it underlined the question of how important resistance was going to become to tuberculosis. In other words, were we really edging towards the end of the antibiotic era? Now, the story was escalated even more a few months later through a chance event that happened began here in the United States, the case of Andrew Speaker, a lawyer from Atlanta in Georgia, who, on the point of getting married and taking a honeymoon in Europe, was diagnosed with tuberculosis and was advised not to travel. Although how strong that advice was is a matter of debate. He travelled anyway because he'd made his wedding plans. He got married in Greece, as that picture on the terrace, bottom right, indicates to you. He was followed by public health officials and then inevitably the media throughout Europe. He was collared in Italy, asked to travel no further. He got on a train, went to Prague, got on an aeroplane, went to Montreal, and then he drove back into the United States, crossing the border with his new wife, and checked into hospital. Now, as all of this was going on, it was being followed by a media storm and a certain number of red faces among public health officials, including ourselves in the World Health Organization. But what this did, and this is where I'm talking about balancing threat and opportunity here. Clearly we had a threat, but in terms of fundraising and in terms of setting policy, we also had an opportunity. And the task that faced us is how are we going to responsibly balance threat with opportunity? Now, we track what makes the news in public health, and this is what happened with respect to tuberculosis between August 2006 and April 2009. Among the media spikes during that period, the most important of these was the Andrew Speaker story, which peaked in June 2007. Now, tuberculosis, and particularly drug-resistant tuberculosis, plays particularly well here in the United States. There seems to be a great fear of drug resistance in general, but particularly multi-drug resistant disease. So it was potentially an opportunity that could be exploited, but one that we needed to exploit in a responsible way. So what I want to try and do is talk to you about the underlying science of drug resistance and tell you where I think we are with respect to the end of the antibiotic era. First of all, the current map of the distribution of extensively drug-resistant TB. As expected, wherever second-line drugs are being used, we find extensively drug-resistant tuberculosis because the pathogen quite quickly develops resistance to any drug you use. But that doesn't mean that resistance will spread unchecked through the community and go to fixation in the population. We need actually to do some more serious analysis rather than just drawing the conclusion that this is drug-resistant tuberculosis rampant and out of control, never mind the fundraising possibilities that are associated with it. So we looked at the data in WHO, me and a group of colleagues, and we tried to reduce the question to very simple scientific terms, and this is it. Imagine that you've got one index case that's sitting in the middle of the picture here. That individual, he or she, generates 2 other cases of tuberculosis that you see in green. So the case reproduction number, as we say, is 2. And each of those cases generates 2 other cases. And you can see in this branching diagram that these spreading cases are all green. In other words, they're all drug sensitive in my imagination in this diagram. But occasionally a red one turns up. Occasionally through bad treatment, an individual patient becomes drug resistant. But what you'll see is that those red ones are a dead end in transmission. Now, if our epidemic really looks like this schematic form, the problem we have to deal with here is drug-sensitive tuberculosis mainly, not particularly drug-resistant disease. Of course, we have to diagnose and treat the resistant patients properly, but the epidemic itself is being controlled by the spread of sensitive forms. And that contrasts with the other possibility, which is not a benign epidemic, but a severe epidemic, as I'm calling it in this scheme, which is the same, except that when you get red resistant forms, they too are generating other resistant forms by spreading through the population. So what are we dealing with when we see the spread of resistance? Are we dealing with, in general, benign epidemics, or are we dealing with severe epidemics? And what implications does that have for the way in which we devise policy on the managing drug-resistant tuberculosis? Well, after an extensive amount of analysis, the conclusion, in short, that we reached is on this slide here. This is the case reproduction number on the vertical axis, so anything greater than 1 is severe, anything less than 1 is benign. In other words, where the bars point downwards, we're dealing with benign epidemics. When they point upwards, we're dealing with a severe epidemic. And you can see, in all the countries that we've managed to gather data from, and they are a somewhat biased selection of countries, we're dealing with benign epidemics, so far as drug-resistant and indeed drug-sensitive forms of tuberculosis are concerned. Because what that means is that the case incidence of all of these different forms of TB is actually slowly drifting downwards. The only exception on the left-hand side was certain provinces of Russia. Now, that's the good news, benign epidemics. The bad news that goes with it is that although they're declining very slowly indeed, and ideally we'd like to speed that up a great deal. But the conclusion we draw from our analysis is that if we could take Russia, the provinces where the spread of resistance was severe, and treat it like other parts of the world where multi-drug resistance was under control, for example here in the United States, then we could change the trajectory of Russia. So just look at the bottom graph, the spread of red points is drug resistance going generally upwards. If we could do what we're doing in the other countries, we could turn that spreading epidemic downwards, in other words, bring resistance under control. Now you might say, well, this is just theoretical calculations, prove that this happens in practice. Well, it is happening in those countries, but since we did this analysis, we have a number of series of data that show that that's what's actually happening. And I was lucky enough to be in China a couple of weeks ago looking at the most recent information on the spread of drug resistance, and remarkably, between year 2000, when they did their last national survey, and 2010, when they've done the most recent survey, the rates of resistance, both of initial on the left-hand side and among retreatment patients is actually going down, not going up. And the tuberculosis epidemic is also in slow decline in China, just as the models that we've used have forecasted. So that's encouraging news. What does it mean in terms of policy? Well, I think what it means in terms of our efforts to scale up the treatment of infection, which is represented on this picture here, this is how many drug-resistant patients we'd like to treat in the coming years, represented by the blue bars. The red bar at the top is the total number we need to treat, about 400,000 a year. The green bars, up until time present, is what we've done so far, which is pitifully few. The blue bars are where we'd like to go in the next few years. That's an enormously ambitious and expensive program. And the message from the analysis, so far as policy is concerned, is by all means attempt to do that. But the results of our calculations suggest don't do it at the expense of basic tuberculosis control. We need the basic programs in place that control drug-sensitive disease, and then we need to do the management of drug-resistant TB as an add-on. Now, how that gets translated into particular practice in countries needs some further investigation, but that's what the results of the analysis say so far. Now, putting this in place, of course, is not just about epidemiology, it's also about local perceptions of public health. And the XDR outbreak that I mentioned to you already in South Africa raised one of the standard debates that's common in infectious disease control, and that's the debate about public health needs versus civil liberties. So some people argue that civil liberties need to be uppermost, the rights of individuals are most important. Others argue that the public health should be given priority. In other words, if you have patients with drug-resistant or extensively drug-resistant TB, they should not be on the streets, they should be detained, they should be in confinement, they should be given the necessary treatment until they're rendered non-infectious, even against their will. And this spread across the newspapers very quickly in South Africa without clear resolution, just as it spread across the newspapers in other parts of the world when that issue has arisen. So that's where we stand at the moment with respect to the management of drug resistance and the science that underpins it. Let me turn now to the second story, which is with respect to HIV/AIDS, the use of treatment as prevention. And I've characterized this in red at the bottom as progress as dissidence. That might be slightly strong words, but as I was thinking about this piece of the presentation, what came to mind was Vasily Grossman's book, Life and Fate, in which he took a swipe at communism, fascism, Christianity, and various other aspects of the Russian society that he was living in up until the 1950s. And as he had done that in the closing years of his life, he speculated about whether or not he would be able to publish Life and Fate before he died. And he was approached by a man named Suslov, who was one of the primary ideologues of the Khrushchev era, who said to him, "You can publish this book, but probably not for about 200 years. Now, I've had manuscripts that have languished in editorial offices, but that really puts it in perspective. But the other aspect of this is to imagine that you could actually write something that would be worth publishing in 200 years. And I think that's a pretty severe test for all of us. Now, Grossman himself was descended upon by the authorities, and he was amazed that what the authorities did was not arrest him, but arrest his book. Now, if I wrote a scientific paper which was arrested, I would be able to draw the conclusion that I think finally I'd actually hit the mark. I'd written something that somebody really cared about. Now, that's background to our own rather small notion of dissidence, which comes into the story about treatment as prevention of HIV transmission. And this is how it begins. It begins with the fact that the criterion for treatment of HIV-positive individuals is their CD4 count, their CD4 cell count, their white blood cell count, essentially. And we in WHO insist on certain thresholds. It used to be 200, it's been raised to 350, which encompasses more people. But if you look at the CD4 data, what you find is that it's extraordinarily variable on every level that you look at it. So if we compare here South African and Zambian populations, The distribution of CD4 count is enormous in both countries, and it's different in these two countries. People living in South Africa who are HIV negative have higher CD4 counts on average, substantially so, than people who live in Zambia. And when they get HIV, of course, they decline, their CD4 counts decline at different rates. Going beyond this, if we look at CD4 in individuals, and this is some data from a friend of a friend who I'll just call Tim here. After Tim became HIV positive, his CD4 count on the left-hand side declined as you see in this picture. Enormous amounts of variation on a day-to-day basis in the measured CD4 count. And you'll see the point midway in this graph on the bottom left-hand side. If he checked into a clinic at this point here, he would have been eligible for treatment under the WHO criteria. If he checked in at any other time, he wouldn't have been eligible for treatment. So one conclusion is to take the science to the policymakers here and say, look, your rule is way, way too simple. You need to use something much more sophisticated. But on reflection, we realized that you can't do that in practical public health. What you need are simple rules. Above all, you need simple rules because they won't be implemented if they're not simple. So you need to put in place the simple rules and then explore the caveats and the uncertainty around using those simple rules. So we've gone with the flow on CD4 count, and we've explored the possibility of treating patients so as to interrupt transmission. Now, there are 34 million people roughly in the world who are infected with HIV. The target for treatment is about 15 million of those. We had the so-called 3x5 initiative, that is 3 million people on treatment by 2005. We didn't make that, but that initiative, as a policy development, was enormously influential in getting people on antiretroviral therapy, to the extent that more than 5 million people were on treatment by the end of 2009. But that's still nowhere near enough. And as my colleague Brian Williams, with whom I've done much of this work, has characterized it, at the top and at the bottom, at the top you see prevalence of HIV, the green fleck is the proportion of those that are on antiretroviral therapy. In the bottom graph you see a small downturn in the mortality rate. You can see that whilst it's encouraging news that more people are on antiretroviral therapy, we're having hardly a dent in the epidemic at the moment. And as Brian has characterized it, we've had 30 years of the epidemic, we've spent $150 billion on it, we've written of the order of 200,000 scientific papers, and what we've got is a tiny downturn in the epidemic. We need to be able to do better than that. So how could we do better than that? The answer to the question in general is that we can use antiretroviral therapy not just for the health benefits of individual patients, but actually to make a serious dent on transmission. And the logic of the calculation of how we do that is simply portrayed in this slide here. This is the way HIV spread in South Africa, and we chose South Africa because the data are good and the epidemic spread relatively quickly. So if we devised a set of rules that would apply for South Africa, we think they would apply more generally in Africa. So what we need to do, as I alluded to with the management of resistance, is we need to get at this case reproduction number. We need to do the calculation which allows us to say what kind of intervention will we need to make sure that the case reproduction number is pushed below 1, which would guarantee the elimination of infection. And in this simple analysis, it turns out that the reproduction number, I won't explain why, is the ratio of the life expectancy to the doubling time in this population. And quite simply, for this very neat set of data in South Africa, that ratio is a life expectancy of 120 months, 10 years from the point of infection, a standard result in HIV. And the doubling time, as we measure from the growth of that curve, is about 15 months. So the ratio of the two is exactly 8. And that means that if we cut transmission by more than a factor of 8, we will be able to push infection in principle to elimination. Now, if people live for 10 years, and if we adopted a policy of testing and treating people once a year, we would cut in principle transmission by a factor of 10. And that's better than the factor of 8 that we need to induce elimination. So that's the logic of our argument. Simply put, that if we could test and treat people on an annual basis, we would have a very substantial effect on transmission, leading ultimately to elimination. Now, we've done the calculation in rather more sophisticated ways than that back-of-the-envelope approach, and here's a sketch that shows what you need to do to get into the green zone, which more or less guarantees that HIV infection would go to elimination in this setting. On the vertical axis on the right-hand side, it's the average time between testing, and to get into that green elimination zone, where the reproduction number is less than 1, that's the 1 in the circle you see there, you need to test more frequently than once a year. And making the best use we can of CD4 counts, you've got to start treating people at somewhere between about 500 and 1,000, which is rather higher than the WHO threshold at the moment. But in principle, it ought to be possible to do that. Can we do it in practice? Should we do it in practice? The paper that we wrote that was associated with this generated an enormous amount of controversy, people arguing, could we do it, should we do it? It's been backed more recently by a clinical trial that shows that it's feasible in practice to use antiretrovirals to stop transmission. This is the so-called now famous 052 trial for those people who've been in the business. This was published in the New England Journal of Medicine. The Lancet's commentary, quite simply, on this, put in the box at the bottom, is HIV treatment as prevention. It works. Okay? So it does work. Can it be implemented or not? We've argued that not only should it be implemented, but it should be implemented rather aggressively. And what we demonstrate in this picture here is that rather than just carry on doing antiretroviral therapy as we're doing at the moment, we should actually front-load treatment. So that's the difference you see in this picture between the red lines, which is business as usual, and the axis, the vertical axis, is the cost of antiretroviral therapy in terms of billions of dollars a year, versus the green lines, which is front-loading treatment to push the infection towards extinction. And what you see is if we do business as usual and follow the red line, in other words, we will just go on paying for HIV and AIDS control essentially forever. If, on the other hand, we're prepared to invest up front and really have an impact on transmission, and not just the clinical benefits, then we can push down transmission and push down, therefore, the future costs of control in about 10 or 20 years. And the question is, are we prepared to try doing that? Do we have the resources to do it? Now, the photograph inset here is the Global Fund, based in Geneva, their replenishment conference held in New York last year, which turns out to have been rather less successful in fundraising than they would have liked. So the money that we'd hoped for that would come from front-loading, that would be needed for front-loading, is not actually available. And the other part of the background here is that when we look at international AIDS assistance across the years, it's risen steeply up until recently, when it's more or less plateaued at around about $8 billion a year of international assistance. And that flatlining has had an influence on the way in which people are thinking about policy in AIDS control, which is not very strongly in favour of what we're proposing. And indeed, this is the outcome of UNAIDS' so-called investment framework, which was released earlier this year, which is very mindful of the fact that the world in total is probably not willing to spend more than about $20 billion a year on AIDS control. And so their policy has rather taken that as a ceiling and asked, what can we most efficiently do with $20 billion a year? Rather than asking the other kind of policy question is, how can we get rid of HIV infection? So this is not, these series of developments with respect to funding within the frame of a larger economic crisis don't favour what we're trying to do. Here in the United States, what happens from now on in terms of this debate is going to be critically important. Now, there's interest in Congress. A letter was written recently from Senator X and Congressman Y. I won't tell you who they are, but they are promoting more effective AIDS control. They have invited Eric Gooseby, who is the administrator of PEPFAR at the moment, who is speaking in Congress later this week, I understand. And the outcome of this decision, I think, is likely to depend here in the US on at least the four people pictured on the right-hand side. Tony Fauci at NIH, Tom Frieden at the Centers for Disease Control, Raj Shah at USAID, and these three people have rather different views, and of course the main man, bottom right-hand side, is also involved in the conversation, I understand, at the moment. So where it'll go in the United States, I really have no idea. But the outcome, the decision about where it'll go, in terms of the way in which PEPFAR spends money on AIDS control, is going to be critically important. Now, various objections have been raised to what we're proposing. One of them is drug resistance. I've had conversations here with a number of people today about the importance of drug resistance. I'm showing you here the important data that have been collected in Vancouver, which demonstrate that when HIV care and treatment is done properly, just look at the top picture, drug resistance rates actually decline, they don't increase. There are similar data from Europe. The downside is that the most recent data from Africa tend to show increases in rates of resistance, and that is a genuine concern that needs further consideration. But another thing that people have said to us is, you can't do test and treat on an annual basis, people just won't come. They won't come in Africa. Well, I think you have to go out and see whether they'll come or not. And this was a setting examined in Kenya, one particular village. People were offered an HIV test. They were offered a drinking straw which sterilized their water, which filtered their water, and they were offered an insecticide-treated bed net. And 41,000 people turned up in a week for HIV testing. So I think we can't draw conclusions about how feasible it is on the ground. We need to put it to the test. So where this is all going is going to depend on what happens on the ground. And it's going to happen at the highest levels of policy and international funding, including here in the United States as well. Whether we can scale up or not depends on other things, such as this was the recent so-called Copenhagen Consensus, which was convened to consider where we should go on HIV/AIDS from now on. This was convened in Copenhagen. Its contributors and panel members included 3 Nobel Prize-winning economists, but most importantly, from my point of view, it didn't include any experts in public health. And the conclusions that they came to was that first thing we should do, scale up vaccine funding by $100 million a year, then introduce male circumcision, infant male circumcision, prevent mother-to-child transmission, that's absolutely fine. But where we stand with test and treat is number 5 on their list. So we have other things going on which are going to deflect the business of reducing HIV transmission at the moment. Now, as for number 1 on their list, I'll come back to it in the 4th section of this talk and say make a few remarks, not particularly about AIDS vaccines, but about TB vaccines. But let me move to the 3rd part of the story, and as I say, parts 3 and 4 of this talk are shorter than the first 2 parts, but they highlight other issues that I think are important that I want to get across. The question here is, can we save 1 million lives lost to tuberculosis among HIV-positive people by 2015? And what this is really about is trying to keep tuberculosis on the public health agenda. As I said at the beginning, tuberculosis has been a pandemic for hundreds, if not thousands of years. And when it comes to infectious diseases, epidemics are news, endemics are facts of life. And tuberculosis has become a fact of life in many of the most endemic countries of the world. And we have great difficulty, despite the number of lives that are lost each year, in keeping tuberculosis in the news. So we need to do more, but we need to do it in a credible kind of way. So here's an argument put very simply. Now, mathematicians in the audience will know that 1 + 1 = 3 for large values of 1. That is an argument that has been used repeatedly in public health, and here's what I mean. It's really a story about stretching the truth behind statistics, or at least being accurate but not quite accurate, but being accurate enough to be persuasive. And it's not actually 1 + 1 = 3, but the 0 word that is used commonly, or the E word in terms of elimination. And the problem that tuberculosis has at the moment is that among the big 3, the holy trinity of AIDS, tuberculosis, and malaria, it's very much the poor relation of those other 2. So HIV/AIDS makes endless claims about what will be achieved. We'll have zero discrimination, we'll have zero new infections, we'll have zero AIDS deaths. And Michel Sidibe, who's the head of UNAIDS at the moment, makes a statement of this kind more or less every week. We'll eliminate mother-to-child transmission by 2015. And malaria, everyone will have a bed net by 2010. We'll end malaria deaths by 2015. These are all out in the public domain as statements, ambitious statements that will be driven by policy. Whereas tuberculosis, we've been much more biomedical and much more conservative in our ambitions with respect to public health. So what we've got are the Millennium Development Goals: halt and begin to reverse the incidence. Well, that's fairly pathetic, actually, compared to the other two. And actually, we've already done that because the number of tuberculosis cases, as I suggested earlier, is already going down in the world year on year. So we've done that. So job done. Is that the conclusion that we should draw from the statistics we have at hand? Obviously not. And we're going to eliminate tuberculosis as a public health problem by 2050. 2050, but from a political perspective, who cares what happens in 2050? You know, politicians operate on a 5-year timescale, not a 50-year timescale. So we need to do something more, but we need to do it truthfully and honestly. And I've been engaged with the Stop TB Partnership, which is the umbrella organisation concerned with communication and advocacy, in trying to find a new way to explain the tuberculosis problem. And just a little background before I get into the substance of this. This is the way in which tuberculosis is driven by AIDS, in a nutshell. This is what happened in Nairobi, in Kenya, between 1980 and just after 2000. The red points are HIV prevalence measured in antenatal clinics. The blue points are tuberculosis cases. And you can see very clearly the one drove the other, and there's a lot of evidence. This is not coincidence, and the time lag is around about 5 years. And that's what's happened all over Africa, but particularly in Eastern and Southern Africa. So we've worked with the Stop TB Partnership to see what can we say that would actually be attractive to donors. And the bottom line, the slogan is, it's time to act, it's time to save 1 billion lives by 2015. And how could we actually justify doing that, and what would be the process? Well, here's the justification very briefly. Top left is a map that shows you the 10 highest burden tuberculosis countries in the world with respect to their link with HIV/AIDS. They're mostly countries in East and Southern Africa. There's Nigeria on West Africa, and then there's India, of course, and one would also put China into this mix as well. But let's just talk about those countries. To the right of that is a picture that shows you that every year about 400,000 people die of tuberculosis who are HIV positive. So if we were going to save 1 million lives of the order of 5 years, do the mental arithmetic here, that's always worth doing in the first instance, 400,000 a year, in 5 years you've got 2 million people who die. That is definitely going to happen. 2 million people will die unless we do something other than what we're doing at the moment. But can we cut that by about half? Could we save about 1 million? Well, let me show you in the bottom picture what the logic of the explanation is. This is an argument that says we have lots of things that we can do to reduce mortality from tuberculosis among people who are HIV positive. And that involves both preventing TB cases in the first place and also treating them more effectively. So if we start with, on the left-hand side, the black bar, 100% of the deaths, that's 400,000. What we need to do in the first instance is 3 things in dark blue at the level of the tuberculosis clinic. We need to get more patients into the clinic. We need to diagnose a higher proportion of those successfully. We need to do that with more sensitive diagnostic tests, which we now have. Molecular tests are now becoming available. And once we've diagnosed TB, we need to make sure we cure those patients, which we could also do more effectively than we're doing at the moment, particularly in Africa. So we need to do those 3 things. If we did it, those 3 things alone at the level of the clinic would cut mortality by about half. You can see that goes down to about 50%. But we can do more than that. Because HIV infection rates are so high in African countries, we can go out into the community, test people to see if they're HIV positive. If they are, follow that with a tuberculosis test. If they do have TB, that many of them will have, treat them properly for tuberculosis there and then, in the community, before waiting for them to walk into a clinic or even dying before they do so. If they don't have tuberculosis, we have a cheap drug that can be administered, isoniazid, that stands a very high chance of preventing them from developing tuberculosis. If we do those things in green, and we put into the mix antiretroviral therapy as well, in principle, we have the technology to cut deaths by around about 80%. So the message to the policymakers is, we've got the tools to do this. It's up to you, the implementers, how quickly you want to implement it. Now, if you do it on the scale of 5 years, then you could save 1 million deaths in 5 years, but we don't mind if it's a little bit longer than that. But do something that's much more effective than is being done at the moment. Now, that message was transmitted publicly at the UN back in the summer at the major annual AIDS meeting. The people at the top are the people who engineered it. The lady on the left-hand side, Ruchika Ditu, is the executive secretary of the Stop TB Partnership. The other key players here on the right, Ray Chambers, a wealthy philanthropist who's now responsible for the Millennium Development Goals for the United Nations, Miss Black America, Michel Sidibe in the middle of UN AIDS, and Jorge Sampaio, the former president of Portugal, were all there to support this event. We took it out onto the streets. The bottom picture there, I think that campaign has now been swept away by Occupy Wall Street, which is having rather a larger effect. We wish we'd managed to come up with a campaign that was equally successful, but Occupy Wall Street is what's on the streets at the moment. Nonetheless, this is beginning to make an impact as an initiative. The governments of several countries are interested in taking this forward in funding particular African countries. The government of Canada, United Kingdom, and 1 or 2 others are expressing interest. So we think that this is an additional impetus. Now, the last section, and I'll deal with it fairly quickly, is looking forward to the future and how can the science that we do drive forward the research agenda, in this instance to develop a better vaccine. And this particular story, so far as I'm concerned, began around about 2005, where we realized that the progress on tuberculosis control was rather slow. So we put together an action plan for tuberculosis control, a roadmap. We called it the Global Plan to Stop TB. It was released at the World Economic Forum in Davos. It was a $50 to $60 billion package, which garnered a substantial amount of support at the time and has maintained momentum. Key figures in the release at the time are the people who you see here. Most of the people since 2006 have now become history, but the key player, second from left, hasn't become history. Bill Gates. Bill Gates promised to spend $900 million on research and development in tuberculosis at the time and has been as good as his word. President Obasanjo of Nigeria, who no longer is, his main contribution to the discussion was to say to Bill, you said 900, why don't you just round it up to 1 billion? Bill said, no, I'll stick with the 900, I think. But has been as good as his word, and the Gates Foundation have been enormously important in funding the development of vaccines, drugs, and diagnostics. Now, here's the problem that we need to solve. If we'd put together, and this is where vaccination comes into the story, if we'd put together the global plan to stop TB, we would go, in our analysis, from about 1,000 per million population cases of TB on the left-hand side. And I couch this in terms of cases per million because the elimination threshold is 1 per million by 2050. So where we need to get to is the bottom right-hand corner of this graph. Where we'd go under that global plan if everybody did what they said they would do, and presuming we had $50 to $60 billion to do it, is we'd follow that red line. And so even if we followed the red line, by 2050, we'd still be 2 orders of magnitude above where we wanted to be with respect to elimination. But the even worse news is that we're not even going along the red line at the moment, we're going along the black line at the top, with a reduction of only a couple of percentage points a year. So how could we possibly go along that green line? Well, here's the opportunity to take a really fundamental look at the way in which tuberculosis biology and epidemiology works, and to say to those people who want to make new technology, this is what you need to aim for. Perhaps not today or in the next few years, but in the next decade or so, you need to have something to do this. What you need to do is to come up with a tool that can be used in an environment like this, typical scene, public health hospitals throughout the developing world. Here are examples in Africa and Asia. We need a system of tuberculosis control that can bypass pretty much all of this. And that really is essentially a vaccine. So the simple analytical logic, which I think contributes to the momentum behind the research agenda, which is now greater than ever, is this. If we imagine we had not just one basic control for TB control, that's a drug to treat active TB, but we had a tool to prevent tuberculosis as well. What could those tools do in combination? And if we had a vaccine in particular, how could we use that vaccine? Well, what we're imagining here is, first of all, we start at the back of this diagram with present incidence around about 1,000 per million population, as I've said. We use both of those measures in combination. We could push incidence down, as you see on that surface there, coming into that green area, which would get us down, we think, by 2050, according to our analysis, everything that we know about TB, to around about 10 per million, not 1,000. So that's 2 orders of magnitude, but we need 3 orders of magnitude, not 2 here. Now, the reason we only get 2 orders of magnitude here is because if you have a vaccine that prevents infection, you essentially have a tool that works in the same way as a drug. Now, a drug and a vaccine are, on the face of it, 2 quite different things, but epidemiologically, they do the same thing. One of them stops infection at source, and the other one stops infection in terms of protecting recipients. So if you can do either one of those things well, there's no point doing the other thing, and that's why we sink to a plateau. What we really need, and this is the message to vaccine developers, is we need a vaccine that not only prevents infection, but one that actually treats those people who already have infection against tuberculosis. In other words, it gets at the latent pool. And if we use those in combination, a vaccine to treat latent infection, plus a drug that we're using at the moment, or even a vaccine that does all of these things, then we're in the dream scenario of getting close to elimination. So that's the principle, and that, I think, is making a contribution to investment in vaccines at the moment. The vaccine pipeline, thanks, I think, to Bill Gates and various other people who have invested in it, and an assortment of arguments, but I would argue the epidemiological argument as well, is that we now have a healthier vaccine pipeline than we've ever had in the history of tuberculosis control. All the details of these candidate vaccines you don't need to know. You can just see that it's about a dozen or so on the left-hand side. The 2 important ones are the ones that are in so-called phase 2B trials, safety and efficacy, some information about efficacy towards the end of phase 2B. The burning question in tuberculosis vaccine development is which of these candidates is going to go into phase 3 in the end. And the reason that's important is because at present we have no immunological marker that tells us what immune protection means for tuberculosis. That means that we have to do a trial with a clinical endpoint for a relatively rare disease. And there's no calculation that's been done so far that says that that will cost less than $100 million. Probably substantially more than that. And so, as a community, the vaccine development community is going to have to get together and say, not my vaccine's better than your vaccine, but this, we agree, is the best candidate, and this is the one that collectively we're going to put into phase 3 multi-center trials. It has to be multi-center because we know vaccine efficacy has been variable with respect to the vaccine that the 2 guys at the bottom right of this picture, Calmette and Guérin, who devised Bacille Calmette Guérin BCG, which is what we use at the moment. It's got to be better than BCG. Well, we will have a vaccine that's better than BCG. That's for sure. It's just not clear how much better. But the analysis, I think, is driving the research policy rather than the implementation, the clinical implementation at the moment. So to round up what I've said, here are the 4 somewhat optimistic answers to the questions that I've posed, with caveats, of course. So first of all, TB. Are we getting towards the end of the antibiotic era? No, not necessarily, provided we don't really mess up with tuberculosis drugs. I think what we're seeing is that it's possible to reverse the spread of resistance at the same time as we're seeing a greater diversity of resistant strains in the world. So we're seeing extensively drug-resistant TB, even totally drug-resistant TB in some populations. But that doesn't necessarily mean that those forms are going to fixation in these populations. And there's strong evidence from a number of countries, the US is one of them, but poorer countries as well, like Estonia, that show that we can turn around those epidemics of drug resistance. Treatment as prevention, where is it going? I think what we've done is to establish, I think the clinical people more than us as epidemiological analysts have established the principle that treatment as prevention works. We're still at the phase of deciding how it can be implemented safely and whether we can raise the resources to do that. TB linked to HIV, can we save 1 million lives by 2015? Frankly, no, we can't save 1 million lives by 2015. But I think that's a much better policy message, even with its caveats, than the messages that we've had so far. And I think that's a step forward in the policy arena. Can we develop a better vaccine? I've talked about tuberculosis vaccines. I think the answer is clearly yes, we will have a better vaccine than BCG. We just don't know how much better that vaccine is going to be. So those are the 4 answers to the questions that I've discussed. There's just one final thing I want to say. I started off by pointing out that I do work for the World Health Organization and that this wasn't a WHO policy talk, this was a personal view. I want to close by giving you my personal view of where WHO stands in the public health arena at the moment. I joined the organization 15 years ago, and just before that, maybe about 20 years ago, around about 1990, the international public health scene and policy development arena looked pretty much as you see it in this picture here. WHO was center stage in international health. It interacted with broadly 2 groups of organizations. Top left, all the government agencies of the wealthy world who were essentially serving as donors, so you'll see some familiar names there like USAID, Centers for Disease Control here in the US and so forth. And bottom right, other UN organizations in blue. And that seemed fairly complicated at the time, but it's nothing compared to where we are today. What's happened in the last 20 years is this. The international health business has gone from a $5 billion annual industry to a $27 billion industry in 2010. And as a consequence of that, it's attracted an enormous number of additional players into this arena. And bottom left, what you see is the proliferation of NGOs who have got into the health business. And they've got into the health business in part because more money has become available, but they've also played their role in accelerating the financing that's been available in international health. And then top right, you have the so-called global health initiatives, the many funding bodies that are now in the business as well. And one of the conclusions that's been drawn very recently from this is that in this environment now with many, many more partners and actors in it, we don't need WHO as an organization anymore because there are bodies out there who can do what WHO historically has done. Well, our argument within WHO is actually quite the contrary. We need WHO or an organization like it more than ever because WHO is really the only agency worldwide who has the responsibility of convening expertise in a disinterested way to provide the best advice, the science essentially, that underlines the health policy, which we then later turn into action. Thanks very much for listening.
I'm Gil Oman, long associated with the university and the school. My wife, Martha Darling. I'd like to thank you very much for a splendid lecture. And thank you also as a wonderful public servant and a knowledgeable public health official. If I may, I'd like to add a little context, because your talk has been so much pegged to the future. That's say many decades of future. It's many of the most important slides with, as was stated, best case scenarios for implementation, lack of corruption, compliance, etc. But there's a little context that might be worth mentioning, and it was triggered by your slide, the most shocking slide, of course, which was, do we use public health approaches, or do we just stand by and watch libertarianism prevail, which is what has happened in this so-called civil liberties argument. We've known for 200 years very effective ways of controlling communicable diseases, and almost none of that has been applied to the HIV/AIDS epidemic. It's worked for a whole host of much more infectious diseases with terrible consequences that are under control globally. We have a long history of success in controlling global infectious threats. And now we're looking at re-emerging diseases that we should be able to handle. We've been less successful with tuberculosis and totally failed on HIV. Even the curves you showed with optimism, the little dip in the last year or two, which we have to see whether it's sustained, is the culmination of a decade of extensive heart treatment for HIV, during which however many lives were saved, more infected individuals emerged. This was Tony Fauci's conclusion after every one of his aspirational talks at the various HIV/AIDS international meetings. The re-emergence of a possible interest in vaccines reminds me that in the 1980s, there was an effort launched by Jonas Salk to produce a killed virus vaccine by tried and true methods. But all my molecular virology friends were so confident that they could come up with a more modern approach to vaccines with HIV that would target specific proteins, specific genes in the virus. And surely that was more scientific than using this killed virus approach, which had worked for so many other vaccines. And basically they ridiculed the approach. Nevertheless, a very expensive, very large, as you described, phase 3 trial was conducted with terrible timing. I had a conversation about this just yesterday in Boston with Bruce Walker, who in fact runs a huge operation, Harvard associated, in Durban. And what happened was, it was decided that you would never want to introduce a vaccine or a drug in South Africa or Zimbabwe or other places, which hadn't first been approved to be used on Americans. After all, if it can't pass the FDA with all the parameters of care and access to care and financing of care in America, it shouldn't be used on anyone else. This is a big ethical discussion. But it wasn't applied to the real world. And it didn't much engage the people in those countries. It was handled at a much more highfalutin level. And the result was that the vaccine was tested again as an addition to heart therapy. Even with 3,000 patients, it was unable to show a further benefit because the survival was so good. Yeah. And Bruce reminded me his own independent studies, small numbers, showed many individual patients who did have very promising responses. So we have a history here of first ignoring public health control measures for infectious diseases. Secondly, turning too soon to biomedical, that's a medical treatment approaches. Back in the 80s, the Institute of Medicine periodic reports that completely brushed aside all behavioral approaches. When we did have a vaccine, a variety of vaccine approaches, the most well-recognized one that might have worked well and been familiar to people all over the world was brushed aside, and the ones that were supposed to be much more scientifically directed all failed. And here we are 25 years later, 30 years altogether, in a rather pathetic predicament. Now, to the wonderful young woman who mentioned about putting more money into AIDS, I'm sympathetic. I mean, in a world where we have unlimited resources, we should do all we can on every disease. But there is pushback in this country and around the world from advocates for many, many other diseases who see that their loved ones and patients are short of funding. And they are amazed. In fact, many of them are trying to duplicate, act up, not very effectively, to bring attention and more open funding to their advocacy positions. We try in the biomedical research community to say we want to support everything, but everything is a big bill. So I laud your efforts. I do think treatment to control has tremendous logic. I think in the practical world it's going to be extremely different, and not just for funding, but for compliance. Wherever there's incomplete therapy for the individual patient, there's a risk of further spread. And I think it would be far more successful if we could incorporate basic public health measures and face up to the civil liberties charges and difficult discussions, which I respect, but I think the consequences have been so devastating that people need to finally address those matters too.
Thank you. We can have more discussion about this later after we talk, and thanks so much for coming. And thank you very much.